The C-47 Skytrain transport plane, call sign Mercy 6, shuddered violently as flak burst around it. Black smoke trailed from its starboard engine as the aircraft lurched downward before the pilot managed to stabilize their descent. Inside the fuselage, amid the cacophony of damaged metal and whining engines, Flight Nurse Lieutenant Catherine Marshall braced herself against the bulkhead while continuing to administer plasma to an unconscious Marine with severe abdominal wounds. "Brace for impact! We're losing altitude!" The pilot's voice crackled over the intercom, barely audible above the howling wind now streaming through multiple shrapnel holes in the aircraft's skin. Marshall looked down at her patient, then at the 11 other wounded men strapped to litters throughout the plane's cabin. Many were post-surgical cases being evacuated from a forward field hospital on Leyte to a general hospital on New Guinea. None were in condition to survive a crash landing, much less the hours or even days they might spend waiting for rescue. As the only medical officer aboard, her responsibility was clear but daunting. These men would die without continuous medical attention, but the aircraft itself had become a flying hazard zone. The Japanese anti-aircraft battery had scored multiple hits, killing the flight's medical technician instantly and severely wounding the flight engineer. Equipment and supplies were strewn across the cabin floor, and several of the litter patients had sustained new injuries from the attack. "Lieutenant, we're diverting to Wendy Atoll," the co-pilot informed her through the intercom. "It's the closest strip we might reach, but it's minimally staffed. No medical facilities, ETA 3 hours, assuming the port engine holds." Marshall nodded grimly, though no one could see her acknowledgement. 3 hours. She glanced at her watch, then at her patients. 3 of them wouldn't survive that long without immediate intervention. The Marine with abdominal wounds was bleeding internally, his dressings already soaked through, despite having been changed less than an hour ago. A young Army lieutenant had a sucking chest wound that needed immediate attention, and the flight engineer, thrown across the cabin during the attack, lay unconscious with an obvious depressed skull fracture. Catherine Marshall was not a surgeon. As a flight nurse, her training had focused on maintaining patient stability during air evacuation, changing dressings, administering medications and fluids, monitoring vital signs, and managing emergency situations until the patients could reach proper medical facilities. Performing surgery at 9,000 feet in a damaged, unpressurized aircraft with limited supplies was beyond any scenario covered in her training. But the alternative was certain death for at least 3 men under her care. A surviving photograph taken months earlier shows Marshall during training at the School of Air Evacuation, a slender woman with determined eyes and capable hands. Former colleagues described her as methodical, unflappable, and possessed of both exceptional technical skill and remarkable adaptability. Catherine could improvise solutions to medical problems that wouldn't have occurred to doctors with twice her formal training, recalled Captain James Wilson, who had worked with her at a field hospital in New Guinea. She had this unique ability to look at what was available and create possibilities no one else could see. This ability was about to be tested to its absolute limits. Marshall secured her current patient, then quickly moved through the cabin, assessing each of the wounded men. She mentally triaged them based on both their original injuries and new trauma from the attack. The Marine with abdominal wounds, Private First Class Michael Rodriguez, was her most critical case. His skin was clammy, pulse rapid but weak, and his abdomen rigid and distended, classic signs of internal bleeding. Beside her, Sergeant Thomas Parker, the crew's loadmaster, waited for instructions. Though not medically trained beyond basic first aid, he had already proven himself invaluable, helping to secure patients and retrieve scattered supplies. "Sergeant, I need to operate on this man," Marshall said, indicating Rodriguez. "Find something we can use as an operating surface, as stable as possible. Then I'll need all the medical supplies you can gather: alcohol, sulfur drugs, plasma, the surgical kit if you can find it." Parker's eyes widened momentarily, but he simply nodded and moved to follow her instructions. Within minutes, he had cleared the area in the middle of the cabin, using a door that had been blown from the latrine as a makeshift operating table. He secured it between two litter stations, creating a surprisingly stable surface. Marshall, meanwhile, retrieved her emergency medical kit and the surgical supplies that had been aboard for emergency use. The attack had scattered equipment throughout the cabin, but between what remained intact in the kits and what she could scavenge, she assembled a rudimentary collection of surgical tools: scalpels, hemostats, forceps, sutures, and a limited supply of sulfur powder and morphine. Sterilization would be nearly impossible in these conditions. The aircraft's galley had been destroyed in the attack, eliminating any source of boiling water. Instead, Marshall used the limited supply of alcohol to clean the instruments as best she could, then instructed Parker on how to prepare the patient while she scrubbed her hands with alcohol and donned the only pair of surgical gloves she could find. "I'm not a surgeon," she told Parker candidly as she prepared to begin. "But without intervention, this man will die before we land. I'm going to try to find the bleeding and stop it. I need you to assist me. Consider yourself promoted to surgical nurse." The next 90 minutes tested every aspect of Marshall's medical training and improvisational ability, working in turbulent conditions with the aircraft periodically dropping altitude or banking sharply to avoid potential enemy aircraft. She performed an emergency laparotomy using techniques she had only observed during her training. The incision revealed what she had suspected: a torn splenic artery that was pumping blood into the abdominal cavity. Using instruments designed for much less complex procedures, Marshall managed to clamp the bleeding vessel and place several sutures to control the hemorrhage. Throughout the procedure, she calmly instructed Parker on how to assist, from retracting tissue to suctioning blood using a rubber tube connected to a manual aspirator. "More light," she requested at one point, never taking her eyes from her work. Parker, thinking quickly, retrieved a flashlight from the emergency kit and held it steady over the surgical field, providing crucial illumination as Marshall worked to control the bleeding that had nearly claimed Rodriguez's life. As she closed the abdominal incision with quick, efficient sutures, Marshall was already planning her next procedures. The Army lieutenant with the sucking chest wound would need a chest tube to re-inflate his collapsed lung, while the flight engineer's depressed skull fracture required immediate pressure relief to prevent fatal brain swelling. Over the next 2 hours, as Mercy 6 limped toward Wendy Atoll, Marshall performed 3 major emergency procedures and numerous minor interventions, converting the damaged aircraft into a flying surgical ward. She inserted a makeshift chest tube using rubber tubing from an IV set and a glass bottle as an improvised water seal drainage system. She carefully elevated bone fragments from the flight engineer's skull using instruments never designed for neurosurgical procedures. Between major interventions, she moved continuously throughout the cabin, checking vital signs, adjusting fluid rates, and providing whatever comfort was possible to the conscious patients. The environment grew increasingly challenging as the aircraft lost altitude, reducing the already minimal cabin pressure and making hypoxia a concern for both patients and the makeshift medical team. Throughout this extraordinary sequence of events, Marshall maintained a composed exterior that belied the immense pressure she was under. Her training had emphasized the importance of projecting calm confidence regardless of the actual situation, a critical factor in managing patient stress during air evacuations. This professional demeanor now served not only to reassure her patients, but also to focus her own thoughts during procedures that stretched far beyond her formal qualifications. 2 hours and 40 minutes after the attack, with the coastline of Wendy Atoll finally visible through the cockpit windows, Marshall completed her final emergency procedure and took stock of her patients. Remarkably, all 12 men were still alive. though several remained in critical condition. Even Rodriguez, whose injuries had initially seemed unsurvivable, was showing improved vital signs following Marshall's emergency surgery. As the damaged C-47 descended toward the small airstrip on Wendy, Lieutenant Catherine Marshall prepared her patients for what would likely be a rough landing. The port engine was now sputtering intermittently, and the pilot had warned that the hydraulics controlling the landing gear had been damaged in the attack. "We're going to touch down hard," she told the conscious patients, securing additional restraints around their litters. "But we've come this far. We're not losing anyone now." Minutes later, as the wheels of Mercy 6 screeched onto the coral runway of Wendy Atoll, no one could have predicted how the emergency procedures performed at 9,000 feet would revolutionize the practice of air evacuation medicine, or that a flight nurse's desperate improvisation would eventually save thousands of lives far beyond that single battle-damaged aircraft. The C-47 Mercy 6 came to a shuddering halt at the end of Wendy Atoll's coral runway, its damaged landing gear collapsing as the aircraft finally settled onto its belly. Inside the fuselage, Lieutenant Catherine Marshall braced against the bulkhead with one arm, while using her body to shield her most critical patient from further injury during the rough landing. As the aircraft's damaged frame groaned and settled, Marshall immediately resumed her assessment of each patient. The rough landing had reopened some wounds and shifted carefully placed equipment, but remarkably, all 12 men, plus the injured flight engineer, remained alive. Wendy Atoll's minimally staffed airfield was unprepared for a medical emergency of this magnitude. The small U.S. Navy detachment assigned to the remote strip maintained the runway primarily for emergency landings and fuel stops, with medical facilities limited to a small aid station staffed by a single pharmacist's mate. As Marshall organized the wounded for evacuation from the aircraft, pharmacist's mate second class Robert Jackson arrived, visibly shocked by the scene that greeted him. The interior of the C-47 had been transformed into something between a surgical ward and a battlefield aid station, with improvised equipment and blood-soaked bandages throughout the cabin. "Ma'am, we've got a jeep ambulance and a small aid station, but no doctor and minimal supplies," Jackson reported. "Nearest medical facility is on Biak, about 180 miles north. They're sending a seaplane, but it won't arrive until morning." Marshall nodded calmly, though the news was worse than she'd hoped. "We'll convert your aid station into a recovery ward. These men need monitoring and continued treatment through the night. Is your aid station at least relatively clean?" "Yes, ma'am. It's basic, but clean." "Good. We'll start moving the patients. Most critical first, the abdominal case, the chest wound, and the head injury." Over the next hour, working with Jackson and Sergeant Parker, Marshall transferred her patients to the small aid station. The facility, little more than a Quonset hut with 6 cots, was quickly overwhelmed, requiring additional space to be created by moving supplies and repurposing the pharmacist's desk as an extra bed. As she established this impromptu ward, Marshall began a more thorough assessment of each patient now that they were on solid ground. Private Rodriguez, on whom she had performed the emergency laparotomy, remained critical but stable, his vital signs gradually improving following the control of his internal bleeding. The Army lieutenant with the chest wound was breathing more easily thanks to the improvised chest tube, which continued to bubble as it drained fluid from around his lung. The flight engineer's condition was most concerning. Despite Marshall's emergency intervention to relieve pressure on his brain, he remained unconscious with increasingly irregular respiration, a sign that cerebral swelling was continuing to progress despite her efforts. "I need to relieve more pressure on his brain," she told Jackson. "Do you have a manual drill in your maintenance supplies? Something with a fine bit?" Jackson's expression reflected his shock at the request. "You're going to drill into his skull. Isn't that, shouldn't a neurosurgeon?" "Ideally, yes," Marshall replied, her tone matter-of-fact despite the extraordinary nature of her request. "But he'll die before morning without intervention. The depressed fracture is causing increased intracranial pressure. I've relieved what I could during flight, but it's not enough." Her calm confidence apparently reassured the pharmacist's mate, who nodded and left to retrieve the requested tool. Marshall, meanwhile, prepared the area, creating as sterile a field as possible with the limited supplies available, and administering the precious remaining morphine to the unconscious engineer. What followed was perhaps even more remarkable than her in-flight surgery. Using a small hand drill sterilized with alcohol, Marshall carefully created a small burr hole in the engineer's skull, adjacent to the fracture site. The procedure, normally performed only by neurosurgeons with specialized equipment, was accomplished with tools designed for aircraft maintenance rather than medical use. As the pressure was relieved, fluid drained from the engineer's brain cavity, and within hours his breathing patterns stabilized and he showed the first signs of returning consciousness, reflexive movements in response to pain stimulus that indicated his brain function was being preserved. Throughout the night, Marshall maintained a constant vigil over her 13 patients. Working with Jackson, she rotated between beds, changing dressings, adjusting fluid rates, monitoring vital signs, and performing additional procedures as needed. When supplies ran short, she improvised alternatives, creating saline solution from available distilled water and salt tablets, fabricating pressure bandages from parachute material found in the crashed aircraft, and using aircraft aluminum to fashion splints for fractured limbs. By dawn, as the promised seaplane approached Wendy's Lagoon, Marshall had been without sleep for over 36 hours. Yet her documentation of each patient's condition, treatment, and response was meticulous. Detailed notes that would later prove invaluable both for the receiving medical teams and for the development of new emergency protocols. The naval medical officer who arrived with the seaplane, Lieutenant Commander James Wilson, was initially skeptical when told about the procedures Marshall had performed. His expression changed to astonishment as he examined the patients and reviewed her documentation. "You performed these procedures in flight with minimal equipment?" he asked, his tone a mixture of disbelief and growing respect as he examined Private Rodriguez, whose emergency laparotomy had undoubtedly saved his life. "I did what was necessary," Marshall replied simply. "These men wouldn't have survived the flight otherwise." Wilson shook his head in amazement. "Lieutenant, I've been practicing medicine for 15 years, including 3 in combat zones, and I've never seen improvised procedures of this caliber. You've essentially rewritten the boundaries of emergency care under austere conditions." As the patients were carefully transferred to the seaplane for evacuation to the fully equipped hospital on Biak, Marshall finally allowed herself a moment of reflection. Her actions had gone well beyond her training, crossing boundaries that normally separated the roles of flight nurses and physicians. She had made these decisions out of absolute necessity, but she was acutely aware that such boundary crossing might not be viewed favorably by the military medical establishment. Her concerns were justified. 2 days later, after catching a transport to Biak to check on her patients, Marshall was summoned to meet with Colonel Robert Hayes, the commanding officer of the 13th General Hospital. As she entered his office, his stern expression suggested she was about to face serious repercussions for exceeding her authority. "Lieutenant Marshall," he began formally, "I've reviewed the reports regarding your actions aboard the transport designated Mercy 6 and subsequently at Wendy Atoll." Marshall stood at attention, prepared to defend decisions that, while unconventional, had saved multiple lives. What happened next would change the trajectory not only of Marshall's career, but of air evacuation medicine itself. Rather than the reprimand she expected, Colonel Hayes rose from his desk and extended his hand. "Your actions represent the highest traditions of military medicine," he said, his formal tone giving way to genuine admiration. "All 13 patients are expected to survive, including the flight engineer, whose prognosis our neurosurgeons initially considered hopeless. 3 of our most experienced surgeons have examined your work, and they're frankly astounded by what you accomplished with minimal training and improvised equipment." The colonel gestured to a chair, inviting Marshall to sit. "What interests me most, Lieutenant, is not just that you saved these men, but how you did it. You developed techniques and approaches that might never have emerged in a conventional medical setting, where standard procedures and specialized equipment are taken for granted." Over the next hour, Hayes had Marshall describe in detail each procedure she had performed, the improvised equipment she had created, and the decision-making process that had guided her actions. As she spoke, he took extensive notes, occasionally asking clarifying questions that revealed his own sophisticated understanding of medical procedures. "Lieutenant, I believe your experience represents something significant beyond the immediate lives you saved," Hayes said, as their discussion concluded. "You've demonstrated that certain emergency surgical procedures can be performed in austere environments by properly trained personnel who aren't surgeons. This could fundamentally change our approach to forward medical care and air evacuation." Hayes explained that he was establishing a special project to develop new protocols and training based on Marshall's improvised techniques. Rather than facing censure for overstepping her role, she was being asked to help formalize and teach the very approaches she had developed under desperate circumstances. "We're calling it the Austere Environment Surgical Program," Hayes told her. "I'd like you to serve as its first technical advisor, helping our surgical staff adapt conventional procedures for use in non-traditional settings with minimal equipment. What you've demonstrated might help us push more advanced care closer to the front lines, potentially saving thousands of lives." This unexpected turn of events marked the beginning of a new phase in Marshall's career and in the evolution of combat medicine. Over the next several months, working from the 13th General Hospital on Biak, she collaborated with surgeons, flight surgeons, and other flight nurses to codify and refine the techniques she had improvised aboard Mercy 6. The program faced significant resistance initially, particularly from traditional medical quarters where strict boundaries between physician and nursing roles were firmly established. Some senior medical officers argued that allowing non-physician personnel to perform procedures traditionally reserved for surgeons would lower standards of care and potentially endanger patients. Marshall addressed these concerns with the same practical approach that had guided her actions during the emergency. "We're not suggesting that flight nurses should routinely perform surgery," she explained during one particularly contentious planning meeting. "We're developing protocols for extraordinary circumstances when the only alternative is death. The question isn't whether a flight nurse's emergency surgery is as good as a surgeon's procedure in a fully equipped operating room. It's whether it's better than no intervention at all when evacuation to surgical facilities isn't possible." This pragmatic perspective gradually gained traction, particularly as reports from forward combat areas continued to identify scenarios where immediate surgical intervention could save lives, but evacuation to surgical facilities was delayed or impossible. By mid-year, the Austere Environment Surgical Program had developed standardized protocols for 5 emergency procedures that could be performed by specially trained flight nurses and medical technicians: control of internal hemorrhage, chest tube insertion, emergency airway establishment, relief of intracranial pressure, and field amputation. These procedures, all derived from Marshall's original improvised techniques, were specifically adapted for performance in aircraft, on small islands, or in other austere environments with minimal equipment. The training program was equally innovative. Rather than simply teaching technical skills, it emphasized adaptive thinking and resource utilization, identifying how common items could be repurposed for medical use when standard equipment wasn't available. This approach, which came to be known as Marshall methodology, represented a significant departure from traditional medical training, which typically assumed access to proper equipment and supplies. As the Pacific Campaign intensified, with operations extending to increasingly remote islands, the value of this new approach became increasingly evident. Flight nurses and medical technicians trained in the austere environment surgical program began saving lives in scenarios where traditional evacuation chain limitations would previously have resulted in fatalities. The program's success eventually caught the attention of senior medical commanders beyond the Pacific Theater. By late in the war, representatives from military medical units in Europe had visited BIAC to observe the training and evaluate its potential application to their theater of operations. Catherine Marshall's sky surgery aboard a damaged C-47 had evolved from a desperate improvisation to a systematic approach that was changing military medical practice throughout the combat zones. Yet the most significant impacts of her innovation would emerge only after the war, as the principles she developed began to influence civilian emergency medicine and disaster response in ways no one could have anticipated during those harrowing hours aboard Mercy 6. When Catherine Marshall boarded the damaged C-47 Mercy 6 as a flight nurse responsible for monitoring stable patients in transit, she could never have imagined that her desperate improvisation would eventually change emergency medical practice worldwide. Yet as her techniques were systematized and expanded through the austere environment surgical program, their potential applications beyond the immediate wartime context became increasingly apparent. Colonel Hayes, whose initial support had been crucial in legitimizing Marshall's approach, recognized that the principles being developed had significance far beyond military medicine. In a memo to the Surgeon General's office, he wrote, "The Marshall methodology represents a fundamental reconsideration of how emergency care can be delivered in resource-constrained environments. While developed to address battlefield necessities, these approaches have clear applications to civilian disasters, remote areas, and any scenario where traditional medical infrastructure is unavailable or overwhelmed." This broader vision began to take shape as Marshall's role expanded from technical advisor to program developer and lead instructor. Working with a team that now included surgeons, flight surgeons, and medical equipment specialists, she refined the 5 core emergency procedures into a comprehensive training curriculum that became known as the Advanced Austere Care Provider (AACP) program. The AACP training was revolutionary in several respects. Unlike traditional medical training, which typically taught procedures under ideal conditions with proper equipment, Marshall's approach started with the assumption of suboptimal conditions and inadequate supplies. Trainees were taught not only the technical aspects of each procedure, but also how to improvise necessary equipment from available materials, skills directly derived from Marshall's original experience aboard Mercy 6. In a perfectly equipped operating room, there's one right way to perform a procedure, Marshall explained to a class of flight nurses and medical technicians. But in an austere environment, there might be a dozen viable approaches depending on what resources you have available. We're teaching you to see medical possibilities in ordinary objects. This philosophy was embodied in the program's unique training exercises. Rather than practicing with standard medical equipment, trainees were presented with scenarios where they had to create necessary tools from items commonly found in aircraft, on small islands, or in jungle environments. They learned to fashion chest tubes from rubber hoses, create traction devices from parachute cord and aircraft parts, and improvise surgical instruments from everyday tools. The psychological aspects of performing advanced procedures under extreme conditions were equally emphasized. Marshall, drawing on her own experience, developed specific training to help providers manage the stress of making life or death decisions beyond their traditional scope of practice. "The hardest part isn't the technical challenge," she told her students. "It's overcoming the voice in your head that says, 'I'm not qualified to do this.' You need to replace that with the more important truth: I'm the only chance this patient has. By late in the war, over 200 flight nurses and medical technicians had completed the AACP program, and the results were impressive. Reports from air evacuation missions and forward medical units indicated that personnel trained in Marshall's techniques had saved at least 140 severely wounded service members who would likely have died under previous protocols. The success of the program attracted attention from beyond the Army Air Force's medical service. Naval medical officers began sending corpsmen for training, recognizing the particular value of these skills for isolated island operations where evacuation to hospital ships might be delayed by weather or enemy action. Even more significant was the interest from Civil Air Transport, the civilian airline that supported military operations across China and Southeast Asia. Recognizing that their aircraft frequently operated in regions without medical facilities, they requested permission to have their flight attendants trained in modified versions of the AACP protocols, the first extension of Marshall's methods to civilian applications. Marshall herself continued to refine the program based on feedback from the field. Each success story and failure was meticulously analyzed to improve the protocols. When a flight nurse reported successfully using a modified version of Marshall's chest tube technique to save a patient with a tension pneumothorax, the variation was evaluated and incorporated into the training. When another provider was unable to successfully control internal bleeding using the taught method, Marshall personally reviewed the case to identify what modifications might have improved the outcome. This iterative, evidence-based approach to developing emergency protocols was itself revolutionary. Rather than relying solely on established medical doctrine, the program evolved based on real-world results in austere conditions. This methodology would later become a core principle of modern emergency medicine, the constant refinement of protocols based on outcome data. As the war drew to a close, the future of the austere environment surgical program became uncertain. Many wartime medical innovations were being discontinued as the military medical system returned to its peacetime configuration. However, several key advocates, including Colonel Hayes and now Major Marshall, argued forcefully that the principles developed should not be lost. In a detailed report to the Army Surgeon General, Hayes wrote, "The Marshall methodology represents one of the most significant advances in emergency medical care to emerge from the conflict. Its principles transcend the immediate military context and offer a framework for addressing medical emergencies in any resource-constrained environment. To abandon these innovations would be to discard hard-won knowledge that could save countless lives in both military and civilian contexts." This advocacy proved persuasive. Rather than being disbanded, the program was restructured as the Advanced Field Medical Training Center, permanently established at the newly expanded School of Air Evacuation. Marshall, now recognized as a leading innovator in emergency medicine, despite her nursing rather than medical degree, was appointed as the center's first director, an unprecedented position for a nurse in the military medical establishment. In this role, Marshall led the transition of her wartime innovations into standardized protocols that would influence both military and civilian emergency care for decades to come. The 5 core procedures first performed aboard Mercy 6 were expanded into a comprehensive approach to emergency care in austere environments, encompassing not only technical skills but also decision-making frameworks, resource management techniques, and psychological preparation. Perhaps most significantly, Marshall developed what became known as the austere assessment algorithm, a systematic approach to evaluating what medical interventions were possible with available resources. This algorithm, which guided providers through a structured evaluation of both patient needs and available materials, became a fundamental tool in emergency medicine, disaster response, and wilderness medicine, long after the specific techniques Marshall had developed were superseded by new medical advances. As military personnel began returning to civilian life, many of those trained in Marshall's methods took these skills into their subsequent careers. Former flight nurses and medical technicians who had completed the AACP program became influential figures in developing civilian emergency medical services, particularly in rural areas where resources were limited and transportation to hospitals often delayed. One such individual was Thomas Roberts, a former flight medical technician who had trained under Marshall and later became the medical director for a rural emergency service in Montana. What I learned from Catherine Marshall wasn't just about performing specific procedures, he recalled years later. It was a way of thinking about emergency care, focusing on what you can do with what you have, rather than lamenting what you don't have. That mindset transformed how we approached emergency care in remote areas where the nearest hospital might be hours away. The influence extended to disaster response as well. When a major earthquake struck Mexico, several former military medical personnel trained in Marshall's techniques were among the first international responders. Their ability to establish effective emergency medical operations with minimal equipment and to train local providers in austere care techniques made a significant difference in the early response phase before conventional medical aid could be fully established. By the 1950s, what had begun as one flight nurse's desperate improvisation aboard a damaged aircraft had evolved into a systematic approach to emergency care that was influencing medical practice around the world. The principles Marshall had developed, adaptive resource utilization, procedure modification for austere conditions, and systematic assessment of medical possibilities, had become fundamental concepts in emerging fields like emergency medicine, disaster medicine, and wilderness medicine. Yet despite this widespread influence, Catherine Marshall herself remained relatively unknown outside specialized medical circles. Like many women whose wartime contributions had changed their fields, her innovations were often attributed to the institutions that had adopted them, rather than to her as an individual. The Marshall methodology became simply austere environment protocols, in many contexts, with her crucial foundational role forgotten or minimized. This began to change in the mid-1950s when the Journal of Aviation Medicine published a comprehensive history of air evacuation medicine, including a detailed account of the Mercy 6 incident and Marshall's subsequent development of austere care protocols. The article, written by Colonel, now retired, Robert Hayes, explicitly credited Marshall as the originator of techniques that had fundamentally transformed approaches to emergency care in resource-limited environments. The publication brought Marshall's contributions to the attention of the broader medical community, leading to invitations to speak at medical conferences and consult on emergency care systems. Now retired from military service and working as the director of nursing at a civilian hospital, Marshall found herself increasingly recognized as a pioneer in what was becoming formalized as the specialty of emergency medicine. This recognition culminated in her appointment as a special advisor to the newly established Division of Emergency Health Services at the U.S. Public Health Service. In this role, she helped develop the first national standards for emergency medical technician training, standards that incorporated many elements of the Marshall methodology, particularly the emphasis on resourcefulness and adaptation to limited equipment. What began as a desperate attempt to save lives on a damaged aircraft has evolved into a fundamental component of how we prepare emergency providers nationwide, Marshall noted during a presentation at the American College of Surgeons. The core principle remains the same. With proper training, emergency care providers can deliver life-saving interventions even in the most challenging environments with minimal resources. As formal emergency medicine residency programs began to emerge in the 1970s, several incorporated specific modules on austere environment medicine that could trace their conceptual lineage directly back to Marshall's work. While the specific techniques had evolved with advances in medical science, the fundamental approach, what one emergency medicine pioneer called the Marshall mindset, remained a crucial element in preparing physicians to function effectively outside fully equipped hospital environments. The full measure of Marshall's impact became clear during the Vietnam War, when military medical evacuation practices incorporated many elements she had developed. Helicopter ambulances, though very different from the C-47 transports of the previous war, operated on principles of en route care that Marshall had helped pioneer. Flight medics, trained in advanced procedures that went far beyond traditional first aid, represented the direct descendants of the providers Marshall had first trained in her austere environment surgical program. When Catherine Marshall passed away in 1985, her obituary, Dr. James Wilson, who received the medal for his work developing emergency care systems in remote rural areas, summarized Marshall's enduring influence. What Marshall gave us wasn't just specific techniques, most of which have evolved with advances in medical science. Her true legacy is a philosophical approach to emergency care, the understanding that with proper training, creativity, and determination, life-saving interventions can be delivered even in the most challenging environments with the most limited resources. This philosophy continues to inform how emergency care is delivered in settings ranging from battlefield aid stations to disaster zones, wilderness areas to under-resourced rural communities. In each of these contexts, providers trained in the conceptual descendants of Marshall's methods save lives that would otherwise be lost due to resource limitations or evacuation delays. Captain Michael Rodriguez, the Marine whose life Marshall saved with her improvised laparotomy aboard Mercy 6, perhaps best captured the human impact of her innovations. 50 years after his near-death experience, at a ceremony honoring Marshall's contributions to military medicine, the retired Marine reflected, "I'm just one of thousands whose lives were saved because Catherine Marshall refused to accept that nothing could be done. Every day I've lived since then, my family, my career, everything, exists because she had the courage to go beyond what she was supposed to do and find a way to save those of us everyone else had written off." Today, the principles Catherine Marshall developed continue to evolve and expand, influencing new generations of emergency providers who may never have heard her name but practice the approach to austere care she pioneered. From wilderness medicine courses teaching improvised chest tube placement to disaster response teams training in field surgical techniques, her legacy lives on in the thousands of patients saved by providers equipped with the Marshall mindset. The damaged C-47. Mercy 6 may have been abandoned on a remote Pacific island, but the medical revolution that began within its fuselage continues to spread. A lasting testament to how one flight nurse's desperate improvisation transformed emergency care worldwide. In the archives of the National Museum of Health and Medicine in Washington, D.C., there is a small display dedicated to Marshall's innovations. It includes her improvised instruments recovered from Mercy 6, her original training manual for the austere environment surgical program, and a simple screwdriver used to perform one of the first field cranial decompressions. Beside these artifacts is a quotation from her own words, taken from the last interview she gave before her death. "I never thought of what I was doing as something revolutionary. I faced a situation where people would die without intervention, and I had enough knowledge to try to help. The real breakthrough wasn't technical, but conceptual. The understanding that emergency care isn't defined by the environment or equipment, but by the provider's determination to utilize whatever resources are available to save lives." This is a lesson I hope will never be forgotten, as it transcends medicine and speaks to our fundamental human capacity for adaptation and overcoming. This philosophy, the refusal to accept limitations when lives are at stake, remains Catherine Marshall's most profound legacy. Each day, in remote places and desperate situations around the world, medical providers face circumstances that seem impossible but find solutions because she proved it could be done. The C-47, Mercy 6, may have flown only once with Catherine Marshall aboard, but her influence continues to circle the globe, saving lives that would otherwise be lost, long after the aircraft has been forgotten to history.